I have a question for, I think, Dr. Anuradha. I just wanted to know what is this liquid biopsy cytology and what is the difference between IHC and ICC?
So liquid biopsy is what we do on the blood samples when we are not able to get the tissue. Liquid cytology is different, liquid biopsy is different. So liquid cytology, when I mean, it's like the sure bath and thin bread which we're using for the gynae pathology. So similarly, we are also having non-gynae vials which we can use for brush cytologies or any cytology material, and instead of brush cytologies wherein currently you are doing the conventional smearing on the slides, you can collect aspirate and rinse that aspirate into these non-gynae vials. Advantage of this is it has inbuilt reagents within it which will break the mucin and the abundant hemorrhage and give you a good tissue. So that is liquid cytology. Liquid biopsy is when you suspect a patient is having cancer but you're not able to do an FNA or any lesion because of comorbid conditions or whatever, but you want to start a therapy for the patient. So in such cases, you can collect the blood sample and send it for molecular analysis. So there you will get a diagnosis and probably a chemomutation burden, which is currently widely used for pancreatic cancers or for lung carcinomas. That is liquid biopsy. IHC is immunohistochemistry, which we do on the 10% coordinate fixed pattern embedded tissue. That is any biopsy tissue which you are giving us, we do additional antibody antigen testing on it. That is, after the routine HLE, we apply certain special stains, and these are specific to lineages. For example, if there is a poorly differentiated malignancy, we do IHC to know whether it's a carcinoma or a neuroendocrine tumor or a lymphoma or a neuron or a mesenchymal tumor. So we apply antibodies according to the morphology. And it helps us to know whether we're dealing with a poorly differentiated adenocarcinoma, squamous cell carcinoma, or neuroendocrine, or a lymphoma, and for the subcategories.
One more question to you.
So in the cytochemistry, normally we do not attempt to do IHC on the cytology slides because when you make cytosmears, the cells are all smeared all over. So you do not have the same amount of cells in each slide. So your application of the antibodies on it may or may not give you an answer.
Ma'am, one more question to you. As a gastroenterologist, we have multiple methods of collecting EUS FNA, such as stylet suction, wet suction, dry suction, heparin suction. So, from the pathologist perspective, do you think all these methods, any of these methods, have higher cellularity or positivity yield to you?
So, we did one study based on one, the size of the needles as well, and the type of the suction or the way you deliver the material onto the slide. So, we have found this stylet method is much better, and sometimes just air pushing the syringe, but not with much force, because it splatters the material. So, there is loss of material rather than getting accurate material. So, stylet material is better.
And how do you deal with when we apply needle syringe suction, the smear becomes more bloody. So how do you deal with that aspirate? Do you try to actively find cells or just inadequate?
So that's why whenever you get a bloody aspirate, all you have to do is just put 2 drops in 2 strips and the rest, the entire material into this formula. Because if you attempt to make 8 slides, 10 slides, 12 slides, till you have exhausted all the blood aspirate into your needles, you are only giving the pathologist multiple slides with scattered cell in 360-degree corners of the slides, and it is impossible. So even the pathologist may not be able to retrieve those cells, and in fact, you may lose out with the diagnosis. So the best way is to just make 2 slides in such case, and in fact, we have seen that the first and the second slide do have material. And the rest, if you put it in your format, you can use it like a FMB.
Thank you.
Dr. Naveen, nowadays surgeons don't ask for EUS, particularly for T1, T2 differentiation, early disease. So, and they say that these latest CT scanners, they are better or equally good. So, what do you feel about the role of EUS in early staging of esophageal cancer?
With the present, whatever I could get the information, there is a role, but its practical utility is, I think, use, I would say, maybe because of the number of the reason, the expertise that is needed, or the operator dependent variations, and some of the limitations, as I told, like if there is a stricture we are unable to cross, and if he has already received any kind of the neoadjuvant treatment. So all this acts as like a barrier marker. So there is a role, but I think practically it is less used. In rectum, yes, there is a utilization of that, but with the present MRI, which is equivalent, so MRI is, can be used as a non-invasive in rectum.
Prakash sir, in which GI cancer practically you feel artificial intelligence is more useful in our country?
Artificial intelligence definitely is going to be the thing in the future, because most of the endoscopes which are going to come probably would be clubbed with an artificial intelligence in the future. One thing, for an experienced endoscopist, for a colonoscopist, you might do all the maneuvers, and you might look at beyond the folds, behind the folds and all, and your pickup rate may not change much. That is what even some of the studies have shown. But someone who is not really experienced, someone early in his career, or persons who are undergoing training, this would help that person detect more lesions. But there is also a caveat that when you are used to this artificial intelligence, probably the learning thing, so you have learned over many years that now, like using a calculator, now you even simple calculation you do with a calculator. The same thing would happen with an artificial intelligence. So when you are learning, you might give those things to the artificial intelligence. So when this is combined with usual colonoscopes and endoscopes, the pickup rate of things will improve, and also narrowband imaging. So when you have to get tuned to many images before you make a good film. But the machine has learned over a period of time how to think, and probably with good artificial intelligence methods, your life also is going to be better. You will pick up more, and your decision making might also improve in the future.
So with this, we conclude the session. Thank you all the esteemed speakers for the wonderful session and discussion. And thank you, Chairpersons. I request you all to join for a group photograph on the stage.